to talk about my background a little bit so that we can build up on why I even involved with the technology. Actually, I'm kind of like the end user, so I'm not the dev member, so not involved much in the development of the technology. But because I've been working in the community setting for quite long, when I say working, I mean teaching students, providing community service to the patient. I still see patient at the community settings, primary care settings, and also doing research in the community. And because of that, I pursue my specialties in community care and home health nursing. And also, because I've been working and sharing my work in my Facebook. So my peer from Michigan has know about that, and we have exchange with students. And that's why I was appointed to be an adjunct professor at University of Michigan School of Nursing. Later on, we saw lots of problem with non-communicable disease, that it is hard to handle and to help with the control, that including the health, mental health that they just been mentioned about too. So I seek the specialty in nurse case management in the NCD problems, and in part of designing innovative technology. I'm a member of the SUT Entrepreneurship Center of Excellence. So I've been using design thinking approach in most of my work. At the same time that I also taught my students how to use that in their work as well. So let's talk about like my belief. So I have lots of belief that built into my work philosophy. So my first belief, I'm a big fan of the King Rama IX. So I believe in the sufficient economy philosophy. When we talk about like we use the people as the center of development. So human-centered design and human approach would be one way that I use to guide into the sustainability of healthcare and also of the self-care of the population so that they can be self-alliance. So, and also doing that, we also think about like community empowerment when we try to train people. When I talk about people, it will be individual, their family members, and also the health volunteers. At the same time, that are my fellow colleagues who work for the healthcare industry as well. And that all in all, every part as a jigsaw, so going to build in the community as a whole. So we saw picture of the community as one picture, but several player would be contributing to the work of developing the healthier community. The major problem in Thailand is that we talk about lots of the non-communicable diseases, and most of the time are lifestyles factor that come into play. How the problem is that the big question is that how should we use what we have for research-based knowledge, technology that we have to improve health and well-being of the population, at the same time to reduce the risk of the population for not getting the community diseases, especially when they are older, they also carry diseases with them when they are old, and they're going to be more burden to themselves and also to the nation as well. So when we talk about the underserved population, we also know that underserved population also have difficulty in terms of access to healthcare. So what make them difficult? The geographic, they are far from the setting, even though right now the most of the Thai population has granted their universal health insurance, but sometimes because of their ill condition, they still need to commute to the hospital to be cared for, especially for those who cannot control for their disease. For example, diabetes with uncontrolled, hypertension that uncontrolled that lead to heart disease and stroke. Socio-economic also are the factors that they are poor. At the same time, they might be illiterate, especially when we talk about technology. They might be like not have enough literacy in terms of using technology to improve their health. Also, language. Every region of Thailand also have their own dialect. In Nakhon Ratchasima area in the northeast of Thailand, they also have their own dialect. And sometimes we miss communication about what does it mean by that. So it's also built into like the hinder of the population into access to healthcare. Another thing is that about like racial and ethnic minority, we saw more people who are in the agricultural sector that sometimes they follow their sprouts from other country around Thailand, for example, Laos and Myanmar or Cambodia, to be in the area, and sometimes their relative work in the factory, but themselves they are somewhere else because they don't have skills. So they will be in hiding in the agricultural fields to work, and also at the same time they also get illness. Another people that have major in those one is disability, and they're underserved because of the age. The more aging that you have, the more difficulty into accessing healthcare. Also, the elderly in Thailand, most of them are responsible to bring about children. They have to take care of their grandkids. So that's another problem as well. Gender and immigrants. So my population actually what make them underserved, they are rural. Most of them are rural. Some of them are suburban. They are poor, they have low income, and also have lack of resource, and also that means that they have some different level of education as well, and disability and aging. When we talk about gender, do you know, my focus right now is on cardiovascular diseases. People who seek less care are male, especially when they think that they're okay, they can handle the symptoms. They think they're okay, even though they have high blood pressure. They just think, okay, nothing, no problem, because I don't have any symptom. So they do not seek care. And most of the time they die from urgency of the illness that are uncontrolled. So how would we help them to have equity into access to care is the one major problem, especially for the underserved population. So my more specific focus, I talk about like rural population, elderly, low literacy population, poor, and also low skill farmers and day labor. Um, I think we cannot work alone. So we need network, and thanks so much for the Health City Network that has me involved and engaged in the network. So we still need lots of partner because we cannot work alone. It's very expensive. It's very difficult in terms of various approach and very different in terms of background and also social cultural background. And doing that, how should we work into improving health of the population? We talk about chronic care model a lot in the healthcare industry. When we talk about healthcare chronic care model, we have the population, especially the underserved, in the middle of the development. And we do have community as close-knit to the people, the family, and to the community. So the patient and the family would get to feel more closer to the community. So we involve into community leader and health volunteer. At the same time, we talk about like healthcare organization. Right now, Thailand has spent lots of money into investing in telemedicine, where the doctor would also complain about there are lots of patients who come to their clinic. They do not have much time to see people through the telehealth. And sometimes, how should we do that? And how can we involve people into the care of themselves? So we think about like, okay, policy also have to build in. We were able to persuade the local administrative office to be part of the development of the care of the community at the same time because of decentralization. So more resources has been distributed to the local healthcare facility better too. And when we talk about that, we just think about like Khon Kaen as the province who want everything big and huge and also have very good infrastructure and contribution. We talk about like in Khon Kaen, my friends had been working with the partner in Khon Kaen to also develop the system to care for people with heart disease, just one disease, heart disease, cardiovascular diseases, especially those who have heart failure after that. But for me, in the rural area, we also poor. As a researcher, we don't have that much money. What are my experiences that I can come into play and use that in working with people in the rural area and underserved population? So my past experience, I was introduced into the design of the innovative approach to promote health and well-being for elderly. The first person who introduced me to that is a professor from Akita University of Japan. He got sponsored from Toyota Foundation, and he has the expensive wearable devices. It's 200,000 baht per piece back then. So we try to understand whether or not season has a different effect onto depression of the elderly. For example, if it is winter, winter come with less light exposure. Whether or not exposure has come into play with the depression. And also the feeling of black and white atmosphere during winter in Japan, whether or not it's different from winter in Thailand and whether or not it affect depression in the elderly. Back then, the device is not because it is listed as a medical devices. We need to have special reading machine to connect to the doc and understand the issue of the people. So the first time that I use the technology is to understand the problem. The second time that I was in part of the team is money that Dr. Sumanthari talked about. The next time is that during COVID-19 and the pandemic, we talk about how we can monitor. Actually, there are like prevention is for the below picture, and the monitor is the upper one. We are the SUT scientists had come up with the portable vital signs that we actually installed in the community isolation. To also we have trained other patients who are not so ill to be able to monitor the symptom and also monitor the device, how to use the device to understand the change in terms of clinic of the patient. And also we talk about clean room technology for to use for collecting sputum for the patient and to test. And currently, I'm working on the project with professor from digital technology department. We try to understand the patient. So I still use the wearable devices. I propose to use the Motion 8 to it is released as a FDA approved, US FDA approved for medical device to understand the quality of sleeping for the patient so that we know the contribution into the problem with the uncontrolled status of the patient in terms of cardiovascular diseases. And after I understand that, we saw that we cannot do well with only the technology. We need to involve community member into the process, as I said before. So what I said, like I agree with David that fail faster and success sooner. So I developed the technology to improve the health outcome of the population. What kind of outcome that I I'm expected to have. They have better skill in terms of knowing what they do that affect health, and they also have the intention to continue the care and also have better health outcome. Using the chronic care model, and I empower the community member to try to use the appropriate technology, which means reliable. It is in the steady state, and the local can adapt and then use that and monitor that one. So my intervention is that I use know your number approach for the population. When they know the number, they know what to do, and so they would use that number to manage their lifestyle, to manage their disease and the symptom. So we simplify the approach and the technology into adjusting the lifestyle of the population. What did I have? I train the health volunteer and healthcare personnel. At the same time, I also train the patient about the disease, talk about the disease, the pathology of the disease, train them how to use the salt meter. And also I got sponsored from Huawei and a practical solution public company to provide the wearable device to detect the ability to sleep, health and spiritual well-being of the population, physical activity of the population, and also use light technology to just communicate with the participants of the project. So all in all, we talk about like technology that used. We found that this is my summary slides. We found that the problem with knowing their number is that sometimes when we talk about like normal range of vital signs, we talk about normal range of this is your kidney function. Just one number that lower than the normal range, they started to worry. So we need to explain more about that. So I think that is the good reason that we integrate the interpret, the health volunteer, and also the health profession into the intervention to improve the care, improve understanding about their situation. And also the problem with that one using technology is that when we use technology on different devices, also they have different platform, the security has come into play, the connectivity is come into play, and sometimes we got the device from partner from outside country for other. I got partner from Russia and also US, Japan that sent the device to me, and the device was stuck at the borders, and sometimes at custom, and we just have to pay. Sometimes we just have to dump that. Forget it. It's too expensive to do that, or even ship it back. So that's the challenge of the technology. But we started to see the positive trend in terms of using technology for the patient to understand the situation and adapt their daily activity into their eating behavior, their physical activities, and manage about their physical and mental well-being of themselves. So, in summary, we talk about like cutting-edge technology alone cannot improve health outcome in the underserved population. We still need lots of human touch in terms of providing explanation, providing guideline, and also being role model for them to guide them into improving their health and well-being, also improve their skill. And that's it for me. Thank you.